Respiratory failure is when the level of oxygen in the blood becomes too low or the level of carbon dioxide becomes too high. A combination of ventilatory and oxygenation failure that often occurs in patients who have abnormal lungs, such as those with chronic bronchitis, emphysema, or asthma attacks. Diseased bronchioles and alveoli cause oxygenation failure, and the work of breathing increases until the respiratory muscles are unable to function effectively, causing the ventilatory failure. A low PaO2 indicates hypoxemia, and the nurse should take immediate action to correct this problem. Almost any condition that affects breathing or the lungs can lead to respiratory failure. Certain disorders such as hypothyroidism or sleep apnea can decrease the unconscious reflex that drives people to breathe. An overdose of opioids or alcohol can also decrease the drive to breathe by causing deep sedation. ABG analysis is useful because it provides information about both oxygenation and ventilation and assists with determining possible etiologies and appropriate treatment. Increasing somnolence will decrease a patient's respiratory rate and further increase the PaCO2 and respiratory failure, so rapid action is needed to prevent a respiratory arrest. Stridor on inspiration is caused by laryngospasm or edema and could be an impending airway occlusion. If a patient's airway is in jeopardy, the physician must take immediate action by prescribing an aerosol vasoconstrictor like racemic epinephrine or intubate the patient. The pathophysiological changes that occur in ARDS are thought to be caused by inflammatory and immune reactions that lead to changes at the alveolar capillary membrane. ARDS is not directly caused by infection, toxins, or fever. Severe illness or injury, however, can cause inflammation that undermines the membrane's integrity, leading to the fluid leakage of ARDS. Managing their fluids carefully is crucial. In the past, patients with ARDS received large amounts of fluids to keep oxygen flowing to other parts of the body. However, too much fluid can increase fluid buildup in the lungs. On the flip side, depriving the body of fluids can put strain on the heart and other organs that depend on the adequate volumes of blood and oxygen to function properly. ARDS can occur when there is a direct physical or toxic injury to the lungs. Examples include inhalation of vomited stomach contents, aspiration, smoke or other toxic fumes, and severe bruising of the lungs that usually occurs after a severe blow to the chest. The second mechanism is more common but less understood. This is an indirect blood-borne injury to the lungs. When a person is very sick or the body is severely injured, some chemical signals are released into the bloodstream. These signals reach the lungs, and the lungs react by becoming inflamed, causing lung failure. Examples of this type of indirect lung injury include the presence of severe infection, sepsis, or severe injury, trauma, the two most common factors in ARDS cases. Other examples are severe bleeding, resulting in massive blood transfusion, severe inflammation of the pancreas, pancreatitis, and some types of drug overdoses. The mechanical cause of ARDS is fluid leak from the smallest blood vessels in the lungs into the tiny air sacs where blood is oxygenated. Normally, a protective membrane keeps the fluids in the vessels. In early ARDS, hypoxemia, noted by increased respiratory rate, may be the only abnormal assessment finding and can be life-threatening. Changes in breath sounds, blood pressure, and ECG patterns would be much later signs of ARDS. The chance for survival is poor when the patient progresses to the fibrotic stage because permanent damage to the alveoli has occurred. ARDS is severe hypoxemia in which the patient is not a candidate for home health or long-term care. The fibrotic stage means a poor patient prognosis. Pulmonary artery wedge pressure will remain at a normal level in a patient with ARDS because the fluid in the alveoli is caused by the increased permeability of the alveolar capillary membrane rather than by the backup of fluid from the lungs, as occurs in cardiogenic pulmonary edema. The purpose of prone positioning is to improve the patient's oxygenation, and this can be seen by improvements in the PaO2 and SaO2. Prone positioning improves oxygenation by changing the distribution of perfusion in the lungs. Although the patient with ARDS may not respond to oxygen therapy to the same degree as patients who have other types of respiratory problems, oxygen is still the most important intervention. Without oxygen therapy, the patient with ARDS will always die of respiratory failure. ARDS is thought to damage the most dependent part of the lungs. So by positioning the patient prone, there is a change in the dependent portions and increased perfusion to the less damaged part. Positioning is an independent nursing function. ARDS is hypoxia that persists even when oxygen is administered at 100%. Ventilatory failure is the physical problems of the lungs or chest wall resulting in poor function of the respiratory muscles, especially the diaphragm. Thoracic pressure changes, which could be normal, and air moves in and out without difficulty but does not oxygenate the pulmonary blood sufficiently. So ventilation respirations are normal, but lung perfusion is decreased. The impairment is the diffusion of oxygen at the alveolar level. Pleurisy is inflammation of the lining of the lung in the chest, which is the pleura, that leads to the chest pain, which is usually sharp when taking a breath or cough. Pleurisy can cause fluid to collect inside the chest cavity. This can make the breathing difficult and may cause cyanosis, coughing, shortness of breath, and tachypnea. Treatment depends on what is causing the pleurisy. Bacterial infections would be treated with antibiotics. Some bacterial infections require thoracentesis to drain the infected fluid. Viral infections normally run their course and you only treat the symptoms. Patients can often control the pain of pleurisy with acetaminophen or nonsteroidals. An intervention would be to apply a hot or cold application as ordered and instruct the patient to lie on the affected side to splint the chest. The body produces pleural fluid in small amounts to lubricate the surfaces of the pleura, the thin tissue that lines the chest cavity and surrounds the lung. A pleural effusion is an accumulation of fluid between the layers of tissue that line the lungs and chest cavity. Absent fremitus on palpation is associated with fluid in the lungs or in the pleural space. There are two different types of effusion that can develop: transudative pleural effusion and exudative effusion. Transudative pleural effusions are caused by fluid leaking into the pleural space. This is caused by elevated pressure in the blood vessels or a low protein content in the blood vessels. Congestive heart failure is the most common cause. Exudative effusion usually results from leaky blood vessels caused by inflammation of the pleura. This is often caused by lung cancer, tuberculosis, pneumonia, drug reactions, and asbestos. A pneumothorax is a collapsed lung and is a collection of air in the space around the lungs. The buildup of air puts pressure on the lung so it cannot expand as much as it normally does when taking a breath. If the patient is on a ventilator and experiencing sudden shortness of breath, this could indicate dislodgement of the tube, occlusion of the tube, or a pneumothorax. Always look at their chest tube if they have one for any drainage greater than 70 mL an hour because that could indicate a hemorrhage. A hemothorax involves bleeding into the thoracic cavity and it decreases lung inflation on the affected side. As a result of decreased lung inflation, percussion sounds become duller and less resonant. Blunt chest trauma can cause an air leak into the thoracic cavity, collapsing the lungs on the side with the air leak. More air enters the pleural space with each breath, increasing intrathoracic pressure on the affected side, moving the trachea to the unaffected side and leading to decreased cardiac output. This condition is life-threatening without interventions. Symptoms of pneumothorax include rapid respiration, reduced breath sounds on the affected side, dyspnea, decreased oxygen saturation, tracheal deviation, and prominence of one side of the chest. Immediate intervention is warranted if the patient has a tracheal deviation because this could indicate the pneumothorax. A collapsed lung may result from chest trauma such as a gunshot or knife wound, rib fracture, or after certain medical procedures, such as a central venous line insertion. In some cases, a collapsed lung can occur without any cause. This is called a spontaneous pneumothorax. A small area in the lung that is filled with air is called a bleb, and it ruptures and the air leaks into the space around the lung. Certain activities may lead to a collapsed lung. Those include scuba diving, smoking marijuana or cigarettes, high-altitude hiking, and flying. Anthrax is an infectious disease caused by bacteria called a Bacillus anthracis. Infection in humans most often involves the skin, the gastrointestinal tract, or the lungs. There are three main routes of anthrax infection. Cutaneous anthrax occurs when anthrax touches a cut or scrape on the skin. Inhalation anthrax develops when anthrax spores enter the lungs through the respiratory tract. Gastrointestinal anthrax occurs when someone eats anthrax-tainted meat. Most people with anthrax are treated with antibiotics, including ciprofloxacin, amoxicillin, and doxycycline. Cutaneous anthrax is treated with antibiotics taken by mouth, normally for 7 to 10 days. When treating inhalation anthrax, a combination of antibiotics should be used. The length of treatment for inhalation anthrax is currently about 60 days, since it may take anthrax spores that long to grow. During a code, the patient will be ventilated with 100% oxygen. Remember that you need to start the chest compressions. If they are pulseless, then you begin the compressions from 100 to 120 beats per minute. Attach a monitor, determine the rhythm. If it's V-fib or pulseless V-tach, they can be shocked. Evaluate the rhythm. If it's pulseless, continue the CPR, and then everything else, making sure the IV access and rhythm-appropriate medications. Indications for mechanical ventilation. You need to decrease systemic or myocardial oxygen consumption, the use of hyperventilation to reduce intracranial pressure, or the need for sedation, neuromuscular blockage. Ventilation abnormalities would be respiratory muscle dysfunction, respiratory muscle fatigue, or chest wall abnormalities. Neuromuscular diseases, you would see oxygenation abnormalities, refractory hypoxemia, the need for positive end-expiratory pressures, and excess work of breathing. The recommended position for patients who have one lung affected by a problem more than the other is to place the good lung down, keeping the healthier lung dependent to the less healthy lung. Such positioning allows gravity to keep more blood in the lower lung, which is the healthier lung, and better ventilation in the upper lung. Positive pressure ventilators require endotracheal or tracheostomy tube and use positive pressure to force the gas into the patient's lung. Inspiration can be triggered either by the patient or the machine. Volume cycle ventilators deliver a preset tidal volume that allow passive expiration. This is ideal for patients with ARDS or bronchospasms, since the same tidal volume is delivered regardless of the amount of airway resistance. This type of ventilator is the most commonly used in critical care environments. Pressure cycle ventilators deliver gases at a preset pressure, then allow passive expiration. The benefit of this type is a decreased risk of lung damage from high inspiratory pressures, which is particularly beneficial for neonates who have a small lung capacity. The disadvantage is that the tidal volume delivered can decrease if the patient has poor lung compliance and increased airway resistance. This type of ventilation is usually used for short-term therapy. Some ventilators have the capability to provide both volume-cycled and pressure-cycled ventilation. These combination ventilators are also commonly used in critical care environment. Flow-cycled ventilators deliver oxygenation until a preset flow rate is achieved during inhalation. A ventilator is used to provide assisted respiration and positive pressure breathing. The oxygen delivered to the patient is warm to body temperature, 98 degrees, and humidified to 100%. This is needed because upper airway passages of the respiratory tree, which normally are warm and humidified and filtered air, are bypassed. Humidifying and warming prevent mucosal damage and ease the clearance of secretions. Mechanical ventilation is an invasive intervention and greatly increases the patient's risk for infection and sepsis, which is a common cause of death in this population. The endotracheal tube should be taped to the upper lip but should never be taped to the lower jaw because the lower jaw moves too much. Communication is integral to decreasing the patient's anxiety. Describing various strategies for communication, like blinking, using your hands, communication boards, are important to decrease the fear and anxiety. Assist control ventilation allows the patient to initiate ventilator breaths and provide the advantage of cycling the ventilator when the patient is ready and lessening the need to suppress the patient's own drive to breathe. In the assist control mode, the number of mechanical breaths is based on the patient's number of spontaneous breaths unless the rate falls below the set ventilator rate. Continuous mandatory ventilation breaths are delivered at preset intervals regardless of patient effort. This mode is used most often in a paralyzed or apneic patient because it can increase the work of breathing if respiratory effort is present. Synchronized intermittent mandatory ventilation delivers preset breaths in coordination with the respiratory effort of the patient. Spontaneous breathing is allowed between breaths. Synchronization attempts to limit barotrauma may occur with intermittent mechanical ventilation when a preset breath is delivered to a patient who is already maximally inhaled, which is called breath stacking, or is forcefully exhaling. Pressure support ventilation is frequently the mode of choice in patients whose respiratory failure is not severe and have an adequate respiratory drive. Pressure is maintained throughout inspiration. It can result in improved patient comfort, reduced cardiovascular effects, reduced risk of barotrauma, and improved distribution of gas. Non-invasive ventilation. With the development of BiPAP, air delivered through a mask can be set at one pressure for inhaling and another for exhaling. It has been found to be especially useful for patients with congestive heart failure and lung disorders, especially those that result in above normal levels of carbon dioxide. Also, if a patient is refusing intubation, BiPAP is an option. This makes BiPAP much easier for users to adapt to and also allows neuromuscular disease sufferers to use the device. Constant positive airway pressure is maintained in the airways, preventing collapse, but the patient regulates all other respiratory function. Can be administered using a mask and a CPAP machine for patients who do not require mechanical ventilation but need respiratory support, for example, patients with sleep apnea. CPAP is similar to PEEP, except that it works only for patients who are breathing spontaneously. The effect of CPAP and PEEP is compared to inflating a balloon but not letting it completely deflate before inflating it again. The second inflation is easier to perform because resistance is decreased. Tidal volume and respiratory rate set the minute ventilation. Too high a volume risks overinflation, too low a volume risks atelectasis. Too high a rate risks hyperventilation and respiratory alkalosis, and too low a rate risks inadequate minute ventilation and respiratory acidosis. The FiO2 is expressed as a number from 0 to 1, 0 being 0% and 1 being 100%. The FiO2 of normal room air is 0.21 or 21%. In adult patients who can tolerate higher levels of oxygen for a period of time, the initial FiO2 may be set at 100% until arterial blood gases can document adequate oxygenation. An FiO2 of 100% for an extended period of time can be dangerous, but it can protect against hypoxemia from unexpected intubation problems. The peak inspiratory pressure is the pressure in the lungs at the end of inspiration. An increase in peak inspiratory pressure in an ARDS patient is indicative of decreased lung compliance, making it more difficult to ventilate the diseased lungs. Increased respiratory rate or tidal volume could trigger a peak inspiratory pressure alarm. The peak inspiratory pressure reflects pressure as air is entering, not leaving the lungs. Positive end expiratory pressure is positive pressure that is applied by the ventilator at the end of expiration. When PEEP is applied without other forms of ventilation, it is called CPAP. PEEP improves gas exchange and oxygenation by preventing alveolar collapse during expiration. Complications of positive pressure ventilation and PEEP include subcutaneous emphysema, decreased cardiac output, lung rupture, and increased intracranial pressure. VQ ratio is V for ventilation, which is the air that reaches the lung. Q is for perfusion, which is the blood that reaches the lung. When ventilation and perfusion match, the ratio is or close to 1. When this ratio is less than 1, ventilation is decreased and is not matched with perfusion. Ventilation and perfusion are not the same throughout, even in healthy lungs. Perfusion is greater at the bases of the lungs, and ventilation is greater at the apices of the lung. So the normal VQ ratio for the entire lung is about 0.8. When the VQ ratio is 0.5, essentially the blood flow through some area is occurring, but the blood is not becoming oxygenated because ventilation is less than adequate. Ventilator complications of decreased cardiac output. This is because the venous return of the right atrium is decreased by a dramatically increased intrathoracic pressures during inspiration from positive pressure ventilation. Also, reduced sympathoadrenal stimulation leads to a decrease in peripheral vascular resistance and reduced blood pressure. Symptoms would be increased heart rate, decreased blood pressure and perfusion of vital organs, or decreased CVP and cool, clammy skin. Treatment is aimed at increasing the preload through fluid administration and decreasing the airway pressures exerted during mechanical ventilation by decreasing the inspiratory flow rates and tidal volume, or using other methods to decrease airway pressure, such as changing to different modes of ventilation. Mechanical ventilation complication, barotrauma. This is damage to the pulmonary system due to an alveolar rupture from excessive airway pressures and/or overdistension of the alveoli. This may result in pneumothorax, pneumomediastinum, and subcutaneous emphysema. The treatment is aimed at reducing the tidal volume, cautious use of PEEP, and avoidance of high airway pressures resulting in development of auto-PEEP in high-risk patients. Patients at risk are those with obstructive lung diseases like asthma and bronchospasms, unevenly distributed lung diseases like lobar pneumonia, or hyperinflated lungs such as emphysema. Another complication is nosocomial pneumonia. Because the ventilator is an invasive device in critically ill patient, it can become colonized with pathological bacteria within 24 hours in almost all patients. 20 to 60% of these will develop nosocomial pneumonia. Treatment is aimed at prevention of avoiding cross-contamination by frequent hand washing, decreasing the risk of aspiration by checking the trachea cuff pressure, use of small bore NG tubes, suction only when clinically indicated using sterile technique, maintain a closed system setup on the ventilatory circuitry and avoid pooling of condensation in the tubing, ensure adequate nutrition, and to decrease acid and gastric contents, use of antacids and H2 blockers. If a patient has decreased renal perfusion, this can be treated with low-dose dopamine therapy. Increase intracranial pressure, you could decrease the PEEP. Hepatic congestion, reduce the PEEP. Worsening of intracardiac shunts, reduce the PEEP. Nursing management to troubleshoot. First, the patient will most likely be anxious while on a ventilator. Remember that respiratory therapy is your friend. Increasing restlessness in a patient being mechanically ventilated may mean that the patient is not receiving sufficient oxygen and may be air hungry. It can also be a symptom of pain. When in doubt, determining the adequacy of ventilation has the highest priority. A wide fluctuating pressure reading is one indication of inadequate flow and oxygenation. The patient may be air hungry from hypoxia. Check the patient's oxygen saturation to determine the adequacy of oxygenation, and if the saturation is less than adequate, increase the flow rate setting on the ventilator. If there are low pressure alarms, it is usually due to a leak in the circuit. Decrease resistance to airflow from the ventilator, as when the tubing becomes disconnected from the ventilator or endotracheal or tracheostomy tube or the chest tube leaks. A high pressure alarm is usually caused by a blockage in the circuit, water condensation, or a kink. Patient could be biting their ET tube or a mucus plug, coughing, secretions, or pneumothorax. If you see a low minute volume, it could be the patient is apneic if they're on a CPAP, or they're disconnected from the ventilator. The 6 P's of dyspnea: pulmonary bronchial constriction, possible foreign body, pulmonary embolus, pneumonia, pump failure, or pneumothorax. Prevention of ventilator-assisted pneumonia, recommended by the Centers for Disease Control and Prevention, consists of elevation of the head of the bed to 30 to 45 degrees, removal of subglottic secretions, changing the ventilator circuit no more than every 48 hours, and hand washing before and after patient contact. The presence of wheezing and bronchi indicate partial obstruction by secretions. Increased intrathoracic pressure can inhibit blood return to the heart and cause decreased cardiac output. Keep in mind that the pilot balloon indicates whether the endotracheal tube cuff is inflated or deflated. A deflated balloon means that the cuff is also deflated and there is no longer a seal around the tube to prevent air from escaping. If the cuff is down, then some of the air being moved into the patient's airway by the ventilator is escaping through the patient's trachea before it reaches the lower airways and alveoli. The endotracheal tube should be positioned and placement maintained with tape or some other type of appliance. Asking the patient to move their mouth and lips could result in possible extubation. Lacerations of the trachea cause massive air leaks, which show as extensive subcutaneous emphysema and air in the mediastinum. Remember, if you are not sure, call respiratory therapy. Do not keep hitting the silence button. If the patient becomes an accidental extubation, then you better hope there's an ambu bag attached to an oxygen flow meter and that it's on. Attach the face mask to the ambu bag, and after ensuring a good seal on the patient's face, start ventilating the patient. A planned extubation. Weaning is the process of going from ventilator dependent to spontaneous breathing. Explain to the patient and significant others, and be sure to maintain privacy. Position the patient upright. If chest PT is required, make sure that it is done at least 20 to 30 minutes prior to the extubation procedure. Ensure NG feeds have been turned off from 4 to 6 hours prior to extubation. Pre-oxygenate the patient with 100% and suction the ET tube and then oral cavity. Remove the tube at inspiration so exhalation can clear secretions. Place the ordered O2 mask and reassure the patient. Be sure to document. Record the date, time of extubation, and continue to monitor and record vitals. Monitor for complications such as aspiration, pneumothorax, atelectasis, and respiratory failure related to premature extubation. Ascertain phonation. Are the cords intact? The voice will be a bit rough. Auscultate breath sounds and document findings as a baseline. Obtain a blood gas 30 minutes post-extubation. Will probably need a repeat chest x-ray. Encourage the patient to deep breathe and cough to prevent atelectasis. Usually, you will leave the ventilator in a room for a few hours in case the patient needs to be reintubated. For VFib or VTAC, medications would be epinephrine, amiodarone, lidocaine, magnesium. Asystole or pulseless electrical activity, epinephrine. Bradycardia, atropine, epinephrine, and dopamine. Tachycardia, adenosine, diltiazem, beta blockers, amiodarone, digoxin, verapamil, magnesium. Acute coronary syndrome, oxygen, aspirin, nitroglycerin, fibrinolytic therapy, heparin, and beta blockers.